The July issue of JPS had several trauma articles that we discussed already. Here's a highlight from part 1.
Interesting. So addressing school preparedness against teachers arming and really reinforcing stop the bleed.
Now, join us for the third and final part.
So the last article we're going to be reviewing is another APSA position statement, and it is child abuse and the pediatric surgeon. So we're going to start with their position statements. Number 1 is that child abuse equals traumatic disease. So it justifies the resource utilization of a trauma system.
Got it. Number 2.
Number 2 is that they support admission to a surgical trauma service to ensure coordination of care.
Got it. So these patients should go to the trauma service. Number 3.
Number 3 is that they support a multidisciplinary team for screening, evaluation, and management of these patients.
Love it. Multidisciplinary team for child abuse patients. Number 4.
Number 4 is the creation of a child abuse team as established by the recommendations with the American College of Surgeons and the Children's Surgery Verification Program.
Got it. So number 3 was that we should have multidisciplinary team approach. Number 4 is saying you actually should have a child abuse team, people that get called on the child abuse cases each time.
Correct.
Number 5.
Number 5 is the systematic evaluation, and this includes having checklists and institutional protocols that you follow every time.
I love this. So this is, again, a standardization thing.
Mm-hmm.
Make it the same way each time so you're not reinventing the wheel. This will eliminate chance of errors. What's number 6?
Number 6 is that any reasonable suspicion of child abuse should be followed by a report. CPS mandates it by law, and a transfer to another facility does not absolve you of this responsibility.
Okay, this is the mandatory reporting thing. So if you suspect at all, even you don't have to think that maybe I'm right or wrong, it doesn't matter.
Mm-hmm.
If you suspect it, you have to have a system to report this every time. What's number 7?
So number 7 emphasizes universal screening. So whatever standardized screening tool you are using, you should apply it across the board, regardless of socioeconomic status, race, ethnicity, or gender.
Alex, out of all the ones you presented, this is the one that I like the most because we have learned that actually we are terrible when we think we can predict when there was child abuse or not. Love that. Number 7, treated them all the same. I do have a question though. What hospitals should probably do is have it set up where if someone meets these criteria, it's not up to opinion. They meet these criteria. For example, a head injury in anyone who's under the age of 6 months, they automatically get moved into the child abuse workup so that there's no emotion involved, there's no opinion involved, it's mandated. Does that exist?
Yeah, it's part of the institutional protocols and recognizing the sentinel injuries and educating and training your providers at all levels to identify these risk factors.
Okay, I love it. Number 8.
So number 8 is about data collection, use of a trauma registry, and reporting to the national trauma databases for benchmarking and quality improvement.
Okay, so I'm assuming most of these places have someone who is responsible for doing the data reporting, and that exists at any trauma center that takes care of child abuse patients. And what's number 9?
Number 9 is that APSA recognizes the existence of abusive head trauma. There's some skeptics out there, but it is a recognized sequelae of child physical abuse. It causes permanent and significant brain damage and neurodevelopmental issues, and we no longer call it shaken baby syndrome. So thanks everyone for joining us. This was the July JPS issue review, and we hope you all learned something special.